Vanakkam. We have learnt about the healing of fractures. This healing can be put on track only by the treatment modality that we adopt. And when we consider the treatment, there are so many bones in the hand that can be fractured, there are so many parts of the bone that can be fractured, and so many types of fractures that can occur. It is not possible to study the management of each and every single type of fracture individually. But what is possible and what should be done is understand the basic principles of fracture management so that it will guide us through the management of any fracture that can occur on the hand. So in this video, we shall deal with the description of fractures in relation to the location, the anatomy, the morphology and the mechanism of injury that caused the fracture. Then we shall learn about the general evaluation of the patient who has sustained a fracture on the hand. And finally, we shall learn about the different modalities of treatment that are available for the fractures. And we shall learn the principles of each of these. Before trying to understand the principles of fracture management, we need to understand everything about the different types of fractures, the clinical picture that is seen when fractures occur, the complete description of fractures, and then we need to understand the basics of fracture treatment and of course finally the principles of fracture treatment. This video deals with understanding fractures, the types of fractures, the clinical picture and the description of fractures. After all, we can treat fractures well only if we are able to understand the fractures well. So first we shall see the different types of fractures that can occur. Fractures can be based on the extent of the break in the bone, the location of the break, the morphology and the mechanism in which it has occurred. Based on the extent of the fracture, it could be complete, that is, a fracture that extends 360 degrees of the bone circumference, that is, all around the bone, as in this example of the radius, which has a complete fracture. Incomplete fractures can be green stick fractures, which means that there is not a break in the bone but a bend. So, one cortex alone will be fractured. In this example, you can see a green stick fracture of the ulna, or a buccal or a torus fracture, which is not a complete break in either cortex, but it is only a deformity, something like a fresh twig that is bent and put back into its position. As in this example of a buccal fracture of both the radius and the ulna. Based on the location of the fracture, it could be in any of the bones. As far as the hand is concerned, it could be in any of the 5 metacarpals, 5 proximal phalanges, 4 middle phalanges and 5 terminal phalanges. It could involve either the right hand or the left hand. And in the particular bone, it could involve any of the parts. That is, the diaphysis, in which it could involve the proximal third, middle third or distal third, the metaphysis, which could be an intra-articular fracture or an extra-articular fracture, or the epiphysis, which can be classified according to the Salter-Harris classification. Based on the morphology of the fracture, it could be classified as transverse, oblique, spiral, wedge, comminuted or segmental, and all these types are based on the orientation of the fracture lines. How this fracture line lies depends on the force that caused the fracture in the first place. If the force was perpendicular to the axis and a tension force, it causes a transverse fracture. This typically transverse fracture line forms an angle of less than 30 degrees with a line perpendicular to the long axis of the bone. And a typical example is a transverse fracture of the shaft of the finger metacarpal. We know that one end of the bone is fixed, and if a force is applied from the other end towards the fixed end, that is, in the form of a compression force, an oblique or compacted fracture results. It is called oblique when it makes an angle of more than 30 degrees to a line perpendicular to the long axis of the bone. An example of this kind of fracture on the hand is the pylon fracture of the proximal phalanx head or the base of the middle phalanx. If, on the other hand, the bone is twisted along its long axis, that is, a torsion force, one end of the bone being fixed, the other end is forced to rotate and ends in what is known as a spiral fracture, which is shown in this example of spiral fractures on the metacarpals. When a bending force is applied which overcomes the elastic limit of the bone and the cortex opposite to the force also breaks, with an additional force causing complete fracture, a butterfly fragment or wedge fracture develops, as in this example of wedge fracture of the ulna. When a force is transmitted along the long axis of the bone, it is transferred to a bone which is peripheral to the axis or protruding outside. This shear force will cause a fracture line parallel to the direction of the applied force, as in this example of fracture of the ulnar styloid or radial styloid. Fractures can be classified even according to the mechanism of the injury. It could be high energy fractures which would have more soft tissue involvement, or it could be low energy fractures which usually result in simple fractures, or pathological fractures where a normal load would result in a fracture of a weakened bone that is involved with a tumor or an osteolytic lesion, as in this example of a pathological fracture of humerus occurring in a patient with an aneurysmal bone cyst. Sometimes repeated load applied to normal bone can result in fractures known as stress fractures, and these are common in military recruits, athletes, and professional dancers like ballet dancers. So far, we have learned that fractures can be of different types based on the extent, location, morphology, and mechanism of injury. When a patient presents with any of these fractures on the hand, there is going to be a typical clinical picture and what we have to do in this situation. That is what we shall be seeing now, the clinical picture. This study is going to consist of two important parts: studying the clinical features and looking into the investigations that are required. Eliciting the history is quite simple in patients with suspected fractures of the hand, like when and how did the symptoms begin. It could have been a specific traumatic incident or a gradual onset. So it could point to either trauma, a pathological fracture, or a stress fracture. If trauma has been the cause of the fracture, we need to get some additional details, like the details of the event, the mechanism of the injury that caused the fracture, the circumstances of the event. Was it work related or was it in the farm or a street? This would indicate the level of contamination, the severity of the symptoms at the time of injury, and the progression after that should also be noted, and any other injuries must also be asked for. If a pathological fracture is suspected, we need to ask for history of prior pain before the event happened, constitutional symptoms that the patient may have had, and history of treatment for the underlying problem. If there is a suspicion of a stress fracture, we need to get the history of the profession and the regular activities of the person, and any history of recent increment of activities that were normally performed that could have led to the stress fracture. Though commonly a patient with a fracture of the hand bones presents with pain, tenderness, or swelling, he can also present with a deformity, a crepitus, loss of function, or nerve and vascular injury. Inspection of the involved hand or finger would reveal swelling, ecchymosis, deformity, or wounds in the case of an open injury. Excessive oozing of dark colored blood from a very small puncture hole on the hand or a protruding bone may point to an underlying fracture. Gentle palpation of the bony landmarks, temperature, distal pulses, and bony tenderness would not be enough. We also need to examine the joint above and below the bone that is fractured. In a patient with a suspected fracture of the hand, we also need to do a thorough examination to rule out neurovascular injury, compartment syndrome, and associated musculoskeletal injuries. Whenever there is a problem on the hand, one of the important steps is to see the range of movements, active and passive, in the joints of the hand. But as far as fractures are concerned, it is not mandatory to check the movements as they may be painful. After having finished a good clinical examination, we need to plan the investigations to confirm and possibly enhance our diagnosis and also plan the management protocol. Obviously, the most important investigation in these cases of suspected fractures of the bones of the hand are X-rays. And as far as X-rays are concerned for fractures of the hand, we need to remember the rule of two. Two views to be taken in order to have a good visualization. Two joints to be visualized, that is the joint proximal and distal to the bone that is fractured, and to be taken two times, one before the treatment and one after the treatment. But before sending the patient for an X-ray, it is very important to splint the hand. It will help tremendously to reduce the pain, to reduce the edema, to reduce the soft tissue injury, and to reduce the incidence of nerve or vessel injury, or if there is already an injury, it prevents the exacerbation of the problem. In most of the cases, the X-ray will reveal the fracture of the bone, but in some cases it may not be very obvious and we may have to depend on additional findings to look for the fractures, like soft tissue swelling. The fat pad sign shows when there is an intra-articular fracture, the joint cavity gets filled with blood, and this displaces the fat that is present anterior and posterior to the joint. This will show up on X-ray as the fat pad sign. Joint effusion is also seen in this manner. Even with all these, if the fracture is not easily visualized, other views or specialized views may have to be ordered for, or an MRI can be done. If the fracture extends to the joint, it is preferable to do a CT scan. We have completed the clinical examination, we have done the investigations, and it is now time to make a diagnosis. A complete diagnosis regarding the fracture, which is going to now guide us towards what treatment is going to be given. So the diagnosis should describe the fracture completely, and that is what we shall be seeing now. In describing a fracture, we should cover these 5 basic points. 1. Whether it is simple or compound. What is the type of fracture? Is there comminution? What is the location of fracture? And is there displacement? And in the displacement, there are 4 different types of displacement that we should mention about. 1. Shortening or distraction, translation, angulation, rotation. Let us see all these in detail and try to understand them. The first point is whether the fracture is a simple fracture or a compound fracture. You can see 2 X-rays here, both showing transverse fracture of the shaft of the proximal phalanx of the index finger. But the one on the left is a simple fracture and the one on the right is a compound fracture. Now let us see the salient features of these compound fractures and try to understand how they differ from simple fractures. Obviously, in the compound fracture, there is skin breach and subsequently more soft tissue injury. There is also more chance of nerve, tendon and vascular injury. Because of the loss of soft tissue support, there is more chance of deformity of the fractured segments. Also, when the fracture is reduced, this same loss of soft tissue support will result in an unstable reduction and the fracture fragments will not stay in place. And most importantly, since the fracture is exposed to the environment, there is more chance of getting infection. So it is important that we recognize the problems that can arise from a compound fracture when compared to a simple fracture. The fracture type is also important, and we have already seen the different morphology of the fracture, that is the transverse, oblique, spiral, comminuted or segmental types. Next, of course, we need to describe the bone involved, the finger involved and the side involved, and within the bone, whether it is the shaft that is fractured, the head that is fractured, the neck that is fractured or the base that is fractured. When there is a fracture, the fractured ends will not stay in the same position but will move to a particular position because of the forces which continue to act on them. The amount that the fractured pieces of bone have moved from their normal location is called the displacement. When describing a fracture, it is very important to describe the displacement also. There may be some fractures that are non-displaced and some which are displaced. The displacement must be described clearly. There are 4 subtypes of displacement that can occur. There can be shortening, translation, angulation or rotation, which can be remembered by the mnemonic STAR. First, we shall see the shortening that occurs due to the fracture. This refers to the amount that the fracture is collapsed, resulting in an apparent shortening of the net length of the bone. It is sometimes called a bayonet opposition since it has a resemblance to the bayonet knife. It is measured in centimeters of overlap of the fractured segments. Next, we shall see the translation that occurs. It refers to the sideways motion of the fracture. It is described as a percentage of movement when compared to the diameter of the bone. Hence, in this diagram, you can see that there has been 50% translation. The next important displacement that we shall consider is angulation. It refers to the amount of bend that occurs between the fractured bones. It is described in degrees and it is described with respect to the apex of the angle or with respect to the direction of the distal fragment. In this diagram, we can see there is a volar angulation with the apex dorsal of 45 degrees. The final type of displacement that we shall discuss is rotation. It refers to the amount a fracture is rotated axially expressed in degrees. Let us now see an example to see if we have understood fracture description. Let us consider this example of a patient with a blunt injury to the middle finger. We have learned the different parameters for describing the fractures and we shall try to describe these fractures too under those parameters. I have already mentioned that it was a blunt injury, so this will come under the category of simple fracture. The morphology of the fracture line is transverse, so it is a transverse type fracture. There is no comminution in the fracture segments and the fracture is located in the diaphysis, that is the shaft of the proximal phalanx of the middle finger, and as far as the displacement is concerned, there is a shortening of about 4 mm with a bayonet opposition, 100% lateral displacement or translation with about 10 degrees of dorsal angulation with apex volar and no obvious rotation, but of course this should be confirmed by clinical examination. Even though we have learnt how to describe the fracture in great detail, there are existing classification systems for fractures. The 3 most widely used classification systems are the AO classification, the Salter-Harris classification for epiphyseal fractures, and the Anderson-Gustillo classification for compound fractures. The AO system is a very detailed system for every bone in the body which has a prescribed number and the part of the bone is also given a subtype. The Salter-Harris classification is for classification of pediatric fractures involving the epiphysis. The Gustillo-Anderson classification classifies compound fractures of the bones. If there is only a puncture wound less than or equal to 1 cm with minimal soft tissue injury, it is classified under type 1. If the wound is more than 1 cm dimension with moderate soft tissue injury with soft tissue coverage of bone adequate and minimal comminution, it is type 2. Type 3 has got 3 subtypes, in which 3A refers to extensive soft tissue damage including contaminated, comminuted or segmental fractures and farm injuries referring to biological contamination, but the soft tissue coverage of the bone is adequate. If there is extensive soft tissue damage with periosteal stripping and bone exposure with a severely contaminated and comminuted fracture requiring a flap to provide soft tissue coverage, it is classified as type 3B. And if it is associated with vascular injury requiring repair for limb salvage, it is classified as type 3C. I hope you enjoyed this video. I enjoyed making it. Please do click on the shown links to see more about the basics of fracture management, that is, fracture healing and the anatomy of the bone. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery and trauma surgery. Vanakkam.